They've been ringing it. Okay, we're going to get started. I've got the pleasure of chairing the next session. My name's Gina Svolos from the Motor Neurone Disease Association of New South Wales. Our next keynote speaker is Samar Aoun. Samar is a professor of palliative care at Trobe University. She is a palliative care researcher with public health approach and a focus on underserved population groups such as people with motor neurone disease, dementia, terminally ill people who live alone, and family caregivers before and after bereavement. Samar advocates strongly for a person-centred health and social care system. Her work on supporting family carers at the end of life and the public health approach to bereavement care has informed policy and practice at a national and international level. Samar is currently the Vice President of MND Association in WA. She's the Director on the MND Australia Board and a member of the Research Committee of MND RIA. She was awarded the Eleanor Muncher Medal in recognition of outstanding commitment, dedication and service to people living with MND and their families. I'd like to welcome Samar to the stage.
Thank you, Gina, and welcome everyone, and thank you very much for the themes of this conference. They really resonate so well with me as a researcher. But as researchers, we do it in a different order. We innovate, and believe it or not, you can innovate when it's not lab-based research. We inform, and we influence policy and practice, but we do it with you. You need to be the conduit for influencing best practice and policy. So this quote from an MND patient really made me think hard. I would like to discuss my longevity as my fear of life is greater than death. People in general are not afraid of death. They are afraid of the journey towards death because it's got anxiety in it, it's got loss of control, it's got loss of dignity, it's got social rejection, social isolation, feeling burden to their families. And this is mainly why people in general, the research say, they want to end their life because, not because pain or anything, but because of loss of dignity. So we can do it better for them. So until there is a cure, the focus needs to be on quality of life, quality of care, and quality of death. And so let's begin with the end of mind. What constitutes a good death? And Smith in 2000, I'll run quickly through this. To know when death is coming and to understand what can be expected. To be able to retain control of what happens. To be afforded dignity and privacy. To have control over symptom management. To have choice and control over where death occurs. To have access to information and expertise to whatever kind is necessary. To have access to any spiritual and emotional support required. To have access to hospice care in any location, not only in the hospital. To have control over who is present and who shares the end of life. To be able to issue advance directives which ensure wishes are respected. To have time to say goodbye and control over other aspects of timing. To be able to leave when it's time to go and not to have life prolonged pointlessly. And if you'd like to read more about it, this is the article. So what are the key elements of palliative care? It provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to hasten or postpone death. It integrates the psychological and spiritual aspects of care. But, and here's the problem, who is receiving palliative care? So the latest articles I published, it looks like more people with cancer are still receiving palliative care in comparison to other non-malignant diseases. And those comparisons are still the same, 64% to between 4 and 10%. And colleagues of mine have done a study 10 years ago, and we're still at the same proportion. So we haven't really moved along in that. In WA, MND patients are accepted usually only in the last 3 months of life to specialist palliative care. if they need ongoing treatment for significant unrelieved symptoms such as breathlessness, secretion management, pain, non-invasive ventilation, and discharge from palliative care if improved or stable. I'm sure it could be the situation in all states. So this is the article if you want to read a bit more on that. But essentially, in much of the Western world now, palliative care has become equated with service provision rather than with its original intent as a philosophy and approach to care. Instead of an upstream orientation, where palliative care begins at the time of diagnosis, care has tended to focus on the last 3 months and weeks of life. And this is the problem. So I've got colleagues in Canada who've got a really good definition of what is a palliative approach to care. It doesn't link care provision too closely with prognosis, but rather promotes early interventions aimed at having conversations with patients and their family members about their goals of care, comfort measures, and needs and wishes. So the person is not defined by their disease or prognosis. There are people who have their own wishes and preferences, and we need to take this into account. They've done a lovely literature review, and this really explains a lot how the palliative approach intersects a lot of concepts that reflect palliative care. We call them hospice care, palliative care, end-of-life care, supportive care, advanced care planning, and on the other side, the chronic illnesses or life-limiting conditions. Again, we all do this palliative approach without calling it that. Now, when you look at the disease trajectories of different diseases, you could see that MND is a downhill from the start, and that's why there is no particular, points where basically you can start palliative care. It needs to start from the start. Mitchell and Borazio looked at this, developing a palliative approach to care, and really need to start from the diagnosis all the way down to bereavement support. So I've put together what are the cornerstones of a palliative approach to MND care. Receiving the diagnosis. I'll go briefly through each one of them. Education in the palliative approach to MND care. The role of the MND associations, and this is where we have this famous quote from Rod Harris, "Until there is a cure, there is care," and it's really traveled the world now, and I'll tell you why. Family carers, the vital partners in a palliative approach. End-of-life care, anticipatory planning. Bereavement support, and I call it the poor cousin of palliative care, because palliative care are not doing a good job there. And then, what is the role of the community in caring, dying, and grieving? Because it's everyone's responsibility. Receiving the diagnosis. The way the patient is told the diagnosis is now recognized to be the first and one of the most delicate steps in palliative care. That's why it's important to really have a good start. Some of the comments on diagnosis from the research I've done: neurologist was clinically thorough but uncaring when providing diagnosis of MND, gave brochure for information, told me I had 3 years left to live, was left alone in the city 2 hours from home after diagnosis. I was told very bluntly about my situation and how it would basically progress. He said if I had any plans to do them now. I felt the neurologist was very insensitive, especially saying it's terminal. I didn't have enough time to comprehend what I've just been told. And then this is one of the partner or the family carer. The diagnosis is almost as bad for the partner. I was hardly considered at all, little or no empathy at all. The neurologist and other doctors just don't understand the needs of the patient's partner in order so that they can better able to cope and basically help. So we asked in 3 surveys, the patients, the family carers, and another survey by neurologists. This is an MNDRA funded project on breaking bad news. And we asked the patients and the carers to rate the ability of their skills. So basically 64% they said their neurologist was above average and 36% below. And that really correlated very nicely with the satisfaction they had when the delivery of the diagnosis happened. So this is how they rated it on the 6 SPIKES protocol. SPIKES protocol is about how do you deliver bad news in a really sensitive, empathic way. So when you look at the emotion particularly, there is a huge difference between those very skilled neurologists and those not so skilled neurologists in how they deliver the diagnosis with empathy. And of course, knowledge comes next in terms of the difference between the 2 groups. Again, what really made the difference for the patient is how long the neurologist spent with them to tell them about the diagnosis and to give them time to respond to their emotions. So you can see they rated the neurologist's ability and skill high or excellent when they've spent about 50 minutes with them rather than the poor about 20 minutes or so. So how are we doing according to international guidelines? All the red is where we need more improvement. So instead of a 20 to 30 minutes consultation, so basically this is taken from the patient survey, the people with MND, what they thought about all that, and then what the neurologists said themselves, and the last column are the guidelines. So the guidelines would say 45 to 60 minutes is really the standard, while our patients got less than that. Of course, this is the average. Patients should not be seen alone. Again, about 20% of patients are being seen alone. Referral to MND association, only 40% of the patients said they were referred, while the neurologist said they were referring 73%. And so on and so on. So really, there's a lot of work to be done here. Now, a word on multidisciplinary clinics, since it was discussed with Susan. Those neurologists who work in multidisciplinary clinics, their practice was closer to the international guidelines than those who were working solo. So this is a good thing to say about multidisciplinary clinics. When I presented this to a group of neurologists, one said to me, "Oh, I think we're doing really fine. I thought we were worse than this." Well, I think a 40% dissatisfaction rate, I didn't think it was good enough. But anyway. And you know, we had the two types of neurologists sort of answer. This one, the empathetic one, said, "Having had a migraine after each MND clinic, feeling stressed and anxious about having so little to offer, I have gradually accepted the limitations of my skills and some confidence that assisting the patients honestly and empathetically and not abandoning them is of value to most patients." Another neurologist thought, well, what's the point of really educating anybody? You come educated. Diagnosing MND is always unpleasant for both patient and physician. I think many physicians don't deliver the news well, but I don't believe it's something that can be taught. Perhaps we should be selecting junior doctors to enter physician training on the basis of their communication skills. I mean, that goes against all the programs that we have in communication. The science is easily learned. Trying to teach empathy, sincerity, and understanding is impossible. Selecting for those qualities is easy. So I leave you with that regarding the diagnosis now. So there's, you know, we published quite a few articles. If anybody wants any, let me know. The second cornerstone is the education in the palliative approach. Now, WHO has defined this or said that it should be adopted by all, not just specialist healthcare professionals, but also general palliative care be provided by primary care professionals who have a good basic understanding in palliative care principles. So 22 different disciplines look after a patient with MND, and I think probably it's represented in this room. We have a lot of you here. So it's quite a labor-intensive disease. And really the report that was commissioned by MNDA for Deloitte Access Economics shows how expensive this disease is. Now, what really surprised me, it's not the health system costs that are really dominating, they're only 17%. It's the productivity and carer costs, they're 54%. And I'm sure we can do better than that. And again, when it was compared to other diseases, the equivalent, this is adding the burden of disease to the economic cost, the equivalent is 1.1 million per person with MND, that's the cost. And you can see all the other ones don't come anywhere near this cost. So, guidelines and multidisciplinary clinics. So as Susan mentioned this, we do have better outcomes when care is coordinated between all these 22 different disciplines and MND association where they are available. They have been shown to be effective in survival time, and also they're able now to integrate palliative care because they have on their team the palliative care specialist with them. So that's great news, and with my colleagues we published this article where we basically talked about how do you improve care in multidisciplinary approach. So how do you educate and train health professionals? We developed the education and training program, not only for MND care providers to know how to do palliative care, but also for palliative care professionals to know really what are the specifics for MND care. And this has worked really well. And it was funded by the National Health Medical Research Council, and it's for everyone to use. So if any MND associations are happy to, we have the PowerPoints and everything. You only need to get the guest speakers basically for the different modules. So, okay, so it's about discussing what's the palliative approach, dignity and quality of life, pathophysiology, the symptoms, communication, psychosocial care, issues for family caregivers, cultural appropriate care, ethical issues, and of course the role of health professionals in providing this. We did an evaluation. Of course, it increased knowledge, confidence, and gave more flexible approach to MND care. For instance, this service provider said that because of that, they were able to communicate better, give extra time, and with the patient. And previous to that, when we first started with them, they were saying they used to freak out when they have a person with MND come to hospital because they just didn't know what to do for them because there was no communication. They didn't know if they were happy, if they were sad, if they were in pain. So I recommend that. Again, it's published if people want to know more about the effect of this program. It's a one day, but it could be done in half a day. And the MND Association in WA has been running it over a few many years now. MND Association, until there is a cure, there is care. And this is really the core of the work of the MND associations. And when I published a paper and I put this title, the editor of the journal told me that the mayor of London, Sadiq Khan, approached him when he was doing a symposium for dementia, and he said, "Can you give me a catchy phrase?" So he said, "Here, read this article." And he was very impressed, so I think he's been using it for dementia actually now, so that's good. But as I said, we give credit to Rod for actually using that, and it's gone now overseas, Rod. So what are the patients and family carers are saying about the MND Association? I was poorly supported until I contacted the MND Association. The MND team took over and have been brilliant. Immediate referral to the association should occur at diagnosis. Prior to that contact, I was in the dark. The information made all the difference, and they helped me in really very tragic situations. So I'm sure you've heard all that from your patients and carers. So when I joined the board of the WA Association after a year, I'm thinking, well, how do we know we're doing a good job? So no surveys have been done or anything. So I've always worked with family satisfaction with palliative care. So I had a really good validated standardized tool that's now internationally used and translated. So I adapted that to MND care. And over the last 3 years, as you see, we have satisfaction survey about 80%. It would have been a lot more if our rural patients were happy, but we don't have enough resources to actually go to regional and rural areas. So they're usually the ones less satisfied, but we've got things in place to actually improve that. Then we asked them the value of the MND advisory service. I really wanted to dig down a little bit more regarding all these aspects that MND advisory service would give. And as you can see, even the carers, like in 90%, they really, really appreciate all these different aspects. So what we do best is that the emotional benefit to the clients, of course, in addition to all the practical benefit, and the particular focus on the needs of the family carers. This is so crucial because they don't get it from anywhere else really in the same way. And I'm sure you've all been, heard that you are professional, supportive, always there and knowledgeable. So the health department, who we give this report to on a yearly basis, sent this email one year. The experience and satisfaction report is at a level not seen in community services reporting. From my perspective, this is an example of best practice. So we're still doing it. And it's important for every MND association to do it. And I'm happy to share this survey if you really want to do it on a real basis. You know why? Because we really need to collect the data and we really need to publish that in peer-reviewed publications. And I tell you what, because the next thing now that we have is a navigation strategy discussion report. And of course, every government wants to know how to save money, how to restructure, how to amalgamate. And what they said in the report, the evidence of effectiveness of any community-based service delivery models in progressive neurological disease was extremely weak in the literature reviewed. So if they're going to base structuring everything because we have not published to tell everybody what a good job we are doing, we are doomed because the funding models are changing really rapidly. So this happened at the same time this article was in press, and that's the one I was talking with, the London Mayor of London was impressed with. So, but we need to have everybody at the national level do that as well. Family carers, they are vital partners in increasing the person-centeredness of health and social care systems. So again, some of the stuff they said in the qualitative work I've done, I think you traumatize, quite frankly, all the symptoms of trauma, numbness, and shock, and all of those things. I turned around and I said, give me a kiss. And I thought at the time he was denying me a kiss, but I realized now he had no muscles in his face to kiss me with. I backed off and I thought, it's not that you've lost feelings for me, it's just that you can't. They should bring back euthanasia, or bring it again, I don't know. You wouldn't put a dog through what MND does. I find it very difficult, it trips you apart. And this is a quote from, my fear of life is greater than death. And they're worried about their loved one, how they're going to leave them through bereavement if they're not well catered for and supported. So bereavement issues are really important. And then this is one lady who said, you go from having a whole army of people, and then you're just alone, left alone after death, basically. So we need to do something. And the UK colleagues of mine, I was part of the international collaboration of family caregiving. They actually designed this tool, Carer Support Needs Assessment Tool, and it really gives the opportunity to systematically hold conversations about the practical, psychological, spiritual, and existential needs. And it goes through a cycle whereby there is, it's 14 items. It's about what do you need to care for yourself as a carer, and what do you need to care after your loved one. So it's what do you need to care for yourself as the carer that's always missing from any service provision. And this is why this is such an important tool to use. I did only a pilot study on this with our clients in WA, and this is the needs. The top 4 is knowing what to expect in the future, knowing who to contact, equipment to help care, dealing with your feeling and worries. And you could see between the first visit and the second visit, because these things were attended to in a timely manner, the need became a bit less at the follow-up time. So when you look at those highest support priorities, what did the nurses, our MND advisors do? For instance, just to give you an idea, knowing what to expect in the future, the discussions that happened with the service provider were around end-of-life issues, advanced health directives, future care, and the role of palliative care. It's the carer who is asking to actually have those issues come up. So there is no awkwardness or, for the service provider to actually introduce advanced care planning. And this really is affirmed by this quote. One of the hardest issues to discuss is end-of-life issues. The form, focused my mind on the need to discuss this, and I ended up talking to people. I spoke to a counselor about end-of-life as a direct result of going through the survey. And then the MND advisor is saying it's interesting through this form to see how the carer needs change over time. But their needs don't always follow the same trajectory as the person with MND, so you cannot stereotype, which some service providers may be doing. Sometimes what I perceive as a very stressful time for the carer, they seem to sail through, whereas something minor for me at another time can unleash a great emotional tide for the carer. So this systematic assessment is able to target the person when they most need it. Oh no, okay. So we've got all these other So this intervention has really reduced the family carer strain and distress during the caregiving period. The articles would say all about that. In fact, people were able to die in the place where they wanted to die because of those conversations that happened. And we've had the ANZ Society of Palliative Medicine really recommend this strong research program in family caregivers and bereavement. Anticipatory planning, again, decisions need to be made in advance of deterioration. Advanced health directives, advanced care planning, all that needs to be put. Again, around the end of life, it's common to have people refuse life-sustaining treatment. And we talked in WA about a central electronic register of advanced health directive. This is an example from one client in our association. And you could see got 3 treatment decisions. They can say, I consent or I refuse consent according to, whatever, it might be happening to them. And then everybody knows about this. Just to let you know that it's a good thing that the palliative care services, we have higher rate of advanced care planning and advanced health directives for people who received palliative care compared to those who didn't. So this is really good, and this is why we need to keep with a palliative approach to care. Okay, bereavement support. Who needs bereavement support and who provides bereavement support? Okay, so this is the public health model for bereavement support. And when you look, we have low risk, moderate risk, and high risk. And I believe from the small surveys that were happening, A lot of the MND carers would be in the high risk period, really, of complex needs for support at bereavement. And we had about 1,000 people from national respond to the survey, and we could really categorize people into low risk, moderate risk, and high risk. I won't be able to now read for you this high risk person, what they said, but then this is really funny. We have somebody with no risk at all. So it's not all bad, really. But anyway. So as you can see, the high risk are the ones who said they didn't have enough support. So we really need to match the risk to the need, and this is what this bereavement survey is able to do. Who's providing the bereavement support? Like, we always knew that the family and friends are doing a lot, but this is the first empirical evidence that 90% of the support is happening in the community. The interesting thing is this: the funeral provider came third, and then the GP. And then it's good that not a lot of people are needing the mental health professionals, which are below down the list. So one of the things that palliative care services need to do for bereavement support is follow people at 3 to 6 weeks, 6 months, or any other time. As you can see, at 3 to 6 weeks, about 50% of people said they were followed up, and that goes down to about a quarter at 9 months, and it's exactly nearly the same in all states. So when we looked at those who did have palliative care and those who didn't have palliative care, it's exactly the same. They reach out for family and friends first, and funeral provider and GP, So we have like a real responsibility to, get everybody into this palliative approach to care. Right, so what we are saying here to palliative care services, reach out to what's available in the community, because that's more sustainable. You don't need to have specialized bereavement support services, because there's enough in the community, but we really need to look after them as assets in the community. So that's what in those two we talked about. It was really reassuring that the UK people have taken this model now into their policy, and that's how they're designing their support, so that's good. Anyway, the last one, the last cornerstone, dying, caring, and grieving is everyone's responsibility. So in the last Productivity Commission, Palliative Care Australia said the desire of thousands of gravely ill Australians to die without pain is going unmet. Tens of thousands will die in a way, in a place that doesn't reflect their values or their choices. And their end-of-life journey is punctuated with avoidable, unwanted admissions to hospital, and as I said, the confusion, the loss of dignity, and loss of control. So this is where we have now, internationally, models of social and practical support, and you as MND associations fit into this. It's really good to see the bigger picture in your work, and it's called the Compassionate Communities Movement. Because palliative care services and specialist palliative care services can't do everything. They're doing a good job with the clinical support, but when it comes to social and practical support, the community has to really be partners now. So compassionate communities is about how we work together and develop those caring networks around the person and the carer. So we're extending this from person-centered care to network-focused care. It's a natural part of life. It's acknowledging that care for one another at times of crisis and loss is not only a task for health and social services, but it's everyone's responsibility. So Julian Abel came with this really encompassing circles of care, starting from the nucleus, the person, then the inner and outer community, and then up to policy, basically, and that's important. And then our team at Trobe University is looking how to connect community networks and health networks, and that is the informal and formal networks. And then, and this is all described in terms of who is useful in those sources of bereavement support and why. Again, it was the external paper of the month at the Cecily Saunders Institute, King's College. So the word is going out to, this is really the best practice model now. And hopefully we're able to do that bereavement survey for MND at the national level and see exactly what are the issues there and the support needs. And also how we do also this carer support needs assessment tool at the national level. And I've had all the MND associations support the two projects. So when we get the funding, it'd be great to get started. So it's good to know that the Irish Hospice Foundation has actually used that bereavement survey, and also it's going to be used in Ontario next year because they want to know the impact of the medical assistant in dying on grief. To put things in practice, we developed our network, Compassion Community Network, in Bunbury and the Southwest, and we started with Mini Death Festival. It was a bit alternative for me, but I had to go with the flow. Yeah, you have seen, I've really gone with the flow. I was painting a coffin as well. At the horror of my kids. They thought I'm completely bananas at the moment. But anyway, but that's really gelled the community together. They really liked the idea. It was very, very successful, and we have a network now that needs to be, basically evaluated as well, whether the social impact is making a difference on the cost in delivery of palliative care. And of course, the health service is very interested, because if we can reduce hospital admissions, that would be great for everybody. I'm not saying just from the dollar terms, I'm saying from the patients and their families. We've got the compassion communities in action, reclaiming aging and dying and grieving. So that's next year in Sydney. The conclusion about the integrated approach. Again, it's all summarized in this article. It's going to be published soon in the European Medical Journal. And let me bring you back to the community, what they said in the MND community survey about the research priorities that MNDA had conducted towards the end of this year, early this year. So you can see top 5 out of 11 priorities. Research to inform health and medical care has come as second, and research to inform social and supportive care has come as 5th. This is really important to know, because we all think that, well, of course, cure, clinical trials are really important, but again, there is other things that are important. Again, when we asked them about research into MND services and support, research into palliative care and support for carers and family members also came high. And this is really basically summarizes my research program across these domains. Just to leave you with this last, oh, sorry, I didn't see you standing here. The drive to find a cure should not detract from the fact that people with MND and their families still need to be supported physically and psychologically until then. Thank you.
We don't really have time for questions, as we are running late, and we'll probably go to lunch late, so don't get too excited about lunch too early. But I'd really like to thank Samar. She's doing an amazing amount of research in the psychosocial aspects of care, which often get missed. So in appreciation for being our keynote speaker, thank you.
Thank you, Gina.
So next I'd like to introduce Mark Whitley. Mark works part-time for MND Queensland as an MND advisor, covering the central Queensland region. He's travelled a long way. He's an accredited mental health social worker with an interest in mental health and end-of-life care. Mark works from a multidisciplinary approach, utilising patient-centred care to ensure holistic care for the client. Thank you, Mark.
Thank you. So not only do you get Mark, but you get me. The reason that I'm also here is mostly to be a voice for Mark today. You'll notice the more he talks, the harder it is to understand him. So I'm kind of here to help with the voice and give him a break, as he's currently undergoing his own investigations for whatever's going on.
Hence I wasn't drinking when I tripped up the stairs. My legs just decide not to work sometimes.
The exciting thing for me is that I'm also a social worker who also works in end-of-life care, so fortunately the topic is something that's not unfamiliar to me as well. So we are talking end-of-life and having difficult conversations. This way. Our overview of what we hope to get through today is an acknowledgement, we want to talk a little bit about some Mind the Gap training that we attended. We want to speak around the last 400 days of life, a little bit about a TED talk that we've seen, some theories and approaches, screening tools, and then the end. So we are acknowledging some training that we did about a year ago. It was called Mind the Gap training. It was a 2-day workshop aimed at those working with individuals living with an advanced chronic or terminal illness, their families and their caregivers. The workshop was developed through the Listen, Acknowledge, Respond, or the LAR project, a Commonwealth-funded collaboration between Charles Sturt University, the Amaranth Foundation and Integrated Living. The project was built around the hypothesis that when appropriate allied health and social work is activated earlier in a patient disease trajectory, there are both qualitative and quantitative improvements in both patient outcomes as well as improvements for families and caregivers. The theoretical knowledge underpinning the 2 days workshop was based on social work values and theories, which really seemed to back up the work that we already do in our jobs. Knowing how to screen and assess for psychological distress and having access to evidence-based therapeutic skills and knowledge to respond appropriately and in a timely, patient-centred way can have a positive impact on a person's quality of life and that of their loved ones. However, we're not here today to talk about mental health and dying. That's a whole conversation for another day. We just wanted to be mindful that everyone is aware that people at end of life may also have mental health concerns. It's our job in this sector to not be afraid to advocate for our clients. Don't be afraid to have these conversations, to talk about mental health and to talk about death and dying.
Okay, 400 days. What if you only had 400 days to live? What does that look like then for you? What does that look like for your family and loved ones? In terms of end-of-life care, the sooner conversations can start around advanced care planning, advanced health directives, end-of-life wishes, or whatever it is you want to name it, the better the outcome may be. What would your journey look like? Who is responsible to ensure your care is appropriate, person-centred, timely, in the place of your choosing, respectful of your values, your hopes, your beliefs, making a difference to you, your living and your dying, and most importantly, respects the experience of your family and loved ones. Who is responsible for your dying with dignity? The answer is we all are.
So we like to watch TED Talks, and there is a TED Talk by physician BJ Miller available on YouTube, delivered by him in March 2015. The video goes for around the 20-minute mark and was tempting to use today just to play the video for you. However, as we need to present so much more, we thought by giving a snippet of what he says in the first couple of minutes may prompt a desire in you to watch the whole thing at a later time. So his presentation is called What Really Matters at the End of Life. And at around the 2-minute mark, he states, healthcare was designed with diseases, not people, at its centre, which is to say, of course, it was badly designed. And nowhere are the effects of bad design more heartbreaking or the opportunity for good design more compelling than at the end of life, where things are so distilled and concentrated. His talk is aimed at encouraging creative thinking within the palliative care sector, and he goes on to say for most people, the scariest thing about death isn't being dead, it's dying and suffering.
Person-centred care. Where am I? Whoa. We didn't feel the need to go too much into this, figuring everyone here works from this approach. Putting the person at the centre of care must be the ultimate goal of any health care professional. Encouraging conversations about end-of-life care as early as possible keeps the client at the centre of your conversations. This is why difficult conversations are a must.
So there are lots of theories and approaches that underpin the work that we do as social workers in end-of-life care. Narrative, dignity, strengths approach, mindfulness, your values and acceptance and commitment therapy. We're assuming that a lot of you have heard of a lot of the theories. Specifically today, we really wanted to use dignity therapy as our approach of choice in end-of-life care, and we'll also touch very quickly on narrative therapy. So dignity therapy was created by, really bad with names, Professor Harvey Chokhanov, thank you, in Canada, and it is a widely accepted approach that is used in palliative care settings. The two websites that I have listed, the first one again has another talk that is Dignity Therapy in Use, and is a gentleman with an MND diagnosis giving a talk about how dignity therapy has been used for him. Again, it's only 7 minutes, so be really awesome to have a look at that. And the second one is a toolkit that gives lots of an overview around dignity therapy.
The key question of dignity therapy is, what do I need to know about you as a person to give you the best care possible? As an MND advisor, I feel that I'm in the unique position of having time advantage to get to know my clients. My goal is to get to know my clients, to understand who they are, what their values are, and what is important to them. I can develop rapport. I often get feedback that every specialist visit, every hospital visit has been very clinical. It's about the disease. I'm told I'm a breath of fresh air as I approach the person as a person with hopes, values, beliefs, and a story, a person with a life-limited condition, but ultimately a person who has family, hopes, dreams, responsibilities. The patient dignity question is useful during every stage of care and treatment. During routine physicals, while carrying out diagnostic testing, when admitting patients, before providing personal care, when considering forms of treatment or therapy, when discussing home care services or long-term care arrangements.
So to break down dignity conserving care, A, B, C and D. So A is around attitudes. Putting yourself in the person's shoes. How would you be feeling in this person's situation? What is leading you to draw these conclusions? Are you aware of how your attitude towards a client may affect them? Could your attitude towards a person be based on something to do with your own life experience, your own anxieties, or your own fears? Use these questions as a prompt during times of reflection, and I'm sure we all spend time reflecting on the care that we provide for each of your clients. And using ongoing professional development activities that have you challenge and question your own attitudes and your own assumptions.
B, behaviour. Take all contacts with clients as you would any important intervention. Professional behaviours towards clients must always include respect and kindness. Act in a manner that shows your client they have your full and complete attention. Always invite your client to have someone from their support network be present, particularly when you plan to discuss or disclose complex or difficult information. Raise personal issues in a setting that attempts to offer respect for the person's need for privacy. As illness and chasing health status can be overwhelming, offer clients and family repeated explanations as they are asking. Present information to clients and family in a way they will understand. Always check in and ask the client if they have further questions. Assure them there will be other opportunities to pose as they arise.
So the C is for compassion. This is about us getting in touch with our own feelings and requires the consideration of human life and experience. Consider any personal stories that accompany illness and show compassion, an understanding look, a touch on the shoulder, arm or hand. Find some form of communication, whether that be spoken or unspoken, that acknowledges the person beyond their illness.
Acknowledgement. Can you talk to it?
So the D is around dialogue, and the first part of dialogue is acknowledgement for your clients, for your patients. Some examples of things that we can say, this must be frightening for you. I can only imagine what you must be going through. It's natural to feel pretty overwhelmed at times like this. D, the dialogue is also about getting to know the person that you're working with. Ask the questions. Besides the patient dignity question that we've already discussed earlier, some other conversation starters can include things like, are there things about you that this disease does not affect? What things did you do before you were sick that were most important to you? What about yourself or your life are you most proud of? What are the things at this time in your life that are most important to you or that concern you the most? What things are still possible? How in control do you feel? What else or who else will be affected by what's happening with your health? Who should be here to help support you? How do you want to be remembered? How at peace are you with what's happening? And are there things that you still enjoy doing on a regular basis?
As I read this, and every time I read this, I am reminded of a client I had who passed away last December. Heading out to his home for my first visit on a sugarcane farm in Bundaberg. It was easy to assume I was going to meet a farmer. By asking these questions, I soon learnt so much more. I got to know a GP, a leader in the sugar community, a gifted public speaker, a devoted husband, loving father and grandfather, and a bloke with a fabulous sense of humour. Of course, this was not all learnt in visit one. This was a process, and I believe he would be absolutely laughing at my attempts of public speaking today. Whilst what we just discussed is by no means an exhaustive list or set of guidelines or having a difficult conversation, they are prompts you can have in your toolkit to be used at any time with your client.
So we really will just flick through the narrative approach because of time. Narrative refers to the emphasis placed on the stories of people's lives. You use therapeutic conversations to hear the stories of people's lives. Narrative therapy is not so much about just passive listening. The challenge is to hear not just what people say, but what's not being said.
Two significant principles that inform narrative ways of working: always maintain a sense of curiosity, so we're not the experts on the person's life, they are. Always ask questions to which you don't know the answers. How do you get to know something about a person? Ask them. Can you do that?
So again, some of the questions that we can use within the narrative approach to expand out a person's beliefs, wishes, values. What do you understand about your condition? How much information would you like me to share with you regarding your condition? What do you already know? How have you managed difficult decisions in the past? Is there anything you're concerned about? Are there any certain forms of care that you think you would never want? And if a client says yes, explore this.
An example of this work as an advisor is such. I arrive for an initial visit with a new referral. I no longer go in assuming they already know all there is to know about MND, nor do I assume they want to know everything. I use questioning to find out what they want from their time together. I will not shy away from a conversation about a time if that is where the client is.
So very quickly, screening tools, again, very useful in the work that we do, and there's a wealth of them out there. We really just wanted to talk about the patient dignity inventory today, which is a series of 25 questions, can be self-administered, a scale of 1 to 5 for the responses, provides a brief snapshot or overview of the client's needs at the particular time.
Questions include feeling depressed, feeling anxious, feeling I'm a burden to others, not being able to think clearly. Maybe I need to take this myself. Just do that.
Okay, so again, this is just, and the presentations I believe are available, and also our notes of all the websites and that we've used for today.
Ooh. Right. Yeah, that'll do.
Thank you.
Okay, thank you. Thank you, Mark, and thank you, Jennie, for your input as well. So moving right along, I'd like to introduce Marianne Vass. Marianne Vass has worked as a clinical liaison nurse at the statewide Progressive Neurological Service at Calvary Health Care Bethlehem for over 10 years. Marianne manages a caseload of 80 to 100 patients who have a diagnosis of motor neurone disease, coordinates care and provides support from diagnosis through to the end stage of disease. I'd like to welcome Marianne to the stage.
Hi. So I'm going to talk to you today about staying one step ahead with a triage call. I'm going to talk about our service provides coordination of care and support through the phone call. Triage can detect changes in disease progression and well-being and helps to identify red flags. It delivers patient education and preparation for clinical discussion and decision making when the patient actually attends the clinic. And I'll share some of the survey results that I did. I haven't got enough time to share it all, but you can get it if you email me, and I'll put my email up a bit later. So at the statewide Progressive Neurological Disease Service, we see 350 patients with a diagnosis of MND in our clinic. And it's at this clinic where we review our patients usually every 2 to 3 months, depending on how quickly their disease is progressing. It can be a bit sooner, it can be a bit later. We work with one of the big public hospitals, the Austin Hospital, and we have the respiratory doctor and the spirometry clinician come out to our clinic, and patients are able to have a respiratory review and do their lung function when they attend. We also introduce the idea of the triage call, a patient shared care panel. A lot of information is given to the patient just so they understand what the role of our clinic is and how we can support them, and how we try to encourage the patient taking ownership of their care and activating appointments in between booked clinic review. So research papers show that people with MND do better accessing a multidisciplinary clinic early, which a lot of people have talked about today. So we have a fabulous group of clinicians and allied health there. And the evolution of the triage call. This first started, I suppose, if you could say, we had a patient booked in and they were going to have a review with their neurologist, a lung function, and let's just say they're going to see a physio and an OT. And during that medical consult, the neurologist identifies this patient's had some changes in their speech and their swallow, and they didn't have an appointment. It was up to the neurologist then to try and negotiate with a speech therapist if they have an appointment available to see this patient. Generally that doesn't happen. Perhaps a speechy might work through a lunch break. Puts a lot of pressure on the clinician, but most of the time we need to turn that patient away to ask them to come back at another day when there's an appointment available. And so this is difficult for patients that are travelling in long distances. Carers often have to take time off if they're still working to bring the patient to that appointment. So this is how the triage evolved. We thought we can do this better, and we'll have a nurse phone a patient a couple of weeks before their review to see if we've got the right appointments for them. And so in doing this, I wanted to ask, is this beneficial? Are patients getting the right service from us that we're providing? So I proposed a survey to assess patients' and clinicians' experience and to see how we can implement any changes. My method was a survey of 9 questions over 2 months, and we gave this survey to 53 patients as they're attending clinic whilst waiting for their appointment. They would fill out the survey anonymously and pop it in a box. We also had 21 clinicians fill out a survey of 6 questions. And the results, majority of patients were satisfied with the triage service and the outcome during their interactions, and both patient and clinician could see the benefit. So triage creates autonomous environment. It identifies any changes in the patient since their last review, and it prepares the patient to make the best use of their clinic visit. And this is done in 3 ways. The majority of the time, the triage call is through a phone call. And generally, this call takes about half an hour, sometimes a bit longer, sometimes a bit less, depending what we're going to unpack. We actually our call comes up as an unidentified caller. And often once a patient comes into clinic and they say they didn't get a call from us, we realise that they say we don't always answer unidentified calls, so sometimes they actually wouldn't receive a call. Often a patient's not wanting to engage in a call, and depending for many different reasons. We might be ringing them and it doesn't suit them, or sometimes they might say, look, I'll just talk to the doctor when I come in, or I'll just talk to the physio when I come in about my problems that I wanted to discuss. And through the call, we don't use a prescriptive protocol. We use domains. So a nurse will ask many questions regarding diet and eating and speech and secretions and moving into sleeping and trying to identify any issues that perhaps a patient may not recognise as due to their MND. Somebody might say, look, I'm waking a lot, my sleep's disturbed, it's just because I'm getting up to go to the toilet. And if we unpack that a little bit further, we may discover that they have a little bit of a struggle breathing, and they may be waking with a headache, and that's a red flag to look at, do we have an appointment with a respiratory doctor? What sort of conversations are we going to be talking about? And it also really is a time where a nurse can help educate a patient to self-monitor, and little by little we're dripping in education. We can't give it all to them collectively at the beginning, but as symptoms are occurring, we're then helping a patient identify this is what we're looking at with that. And we also let the patients know that they can ring the clinic at any time. We don't have to wait till the nurse is calling a couple of weeks before their review. If you have any issues, please call us and we can make an earlier appointment. The second way that we do our triage call is by email, and we do inform patients that this isn't a secure and confidential form of communication, but it's very, very useful for the patients that fatigue when they're talking a lot, or our patients that are anarthric and they have no speech. And just recently we're trialling and testing email to text, which is going to be great. We might capture those patients that don't answer the unidentified callers. We can actually email them and say, I'd like to give you a call. Will it suit you tomorrow? Will it suit you in 1 hour? So with my survey, 75% of patients said the nurse helped identify new problems. 23% of patients said the appointments changed as an outcome. And I'd like to give you an example of a recent triage call with this lovely gentleman. He's a 73-year-old man who was diagnosed 18 months ago with limb-onset MND. And he said that his way of coping, his strategy was to pack his MND away in a box and put it out of sight until he had to make some decisions about different things. And he was implemented on non-invasive ventilation. He made the decision to have the insertion of a feeding tube. But this, I probably called him maybe 9 or 10 times within that 18 months to do a triage call. And he was one of those gentlemen that didn't want to engage with me, and that was okay. He was happy to talk with the clinicians when he came into clinic. But this particular day, I called at a very vulnerable time, and he was deeply challenged by his physical disability, that he no longer could do what he was able to do, and his strategy of packing his MND away in a box, he could no longer do that. And so we talked about different things, different experiences that he was having, and I thought it was a perfect opportunity to introduce clinical psychology. And we talked about the benefits of that, and he agreed. He thought that would be great. I could see that there weren't any appointments available on the day he was coming in. So I said, what we'll hope for is a cancellation, or otherwise you'll have to come at another time. I then emailed, after the call, I emailed the clinical psychologist, and just flagged with her to keep her eye open if there were any cancellations on the day to slip this gentleman in. As it turned out, there was an availability, but on the day this gentleman declined and didn't want to take on that appointment. So that was a referral for clinical psychology. The next thing we unpacked was he was saying his sleep was a bit disturbed and his breathing mask was no longer fitting nice and tight and snug. Perhaps he was having changes with the structure of his face with muscle wastage. So I referred him to the Austin Hospital that I mentioned earlier, also has an outreach service, and they can come out to the home and do a mask fitting and change his mask, or perhaps meet him in Bethlehem at our outpatient clinic. And the other thing that we unpacked is constipation. Again, here I was educating this gentleman that he was having very early signs of constipation, started him on a bowel regime, and I said that we'll follow that up when he comes into clinic and we'll see how we're going. If he has any issues in the meantime, to give me a call. And I thought this was a perfect example, a nice segue into introducing palliative care. And my experience, there still is a bit of a stigma out there when you mention the word palliation. So I really discuss that and try and unpack that with patients, and I let them know that, you know, the word palliative is sometimes scary for people. Please don't think I'm thinking you're going to die next week or next month. We often use this service for many years in a situation like this. However, this gentleman declined that referral. But I have to say, when he came into clinic, it was then discussed a little further with his neurologist, and he did accept the referral to the palliative service. So some of my survey questions: did the triage call help prepare you for discussion or decisions for your clinic review? 66 patients agreed, 32 said neither, and 2% disagreed. We asked, did you see benefit in receiving a triage call prior to your clinic review? 88% of patients agreed. We have difficult conversations sometimes on the phone, and it made me think, are we causing anxiety? It's something that I'd really like to know, and I was pleased to hear that it was only 4% of patients become anxious, and that's understandable with some of the conversations that we are having. We asked, did you feel the clinician was well informed and the triage information had been communicated to them? And 85% said yes. And some of the comments from the patients: I believe it helps the appointments run smoothly and helps prompt questions I may have forgotten. I didn't get a call. The nurse provided advice from experience, very valuable. And I really like having email communication. It takes the anxiety out of my concerns. And the triage call helps me clarify my thoughts and focus on my most important issues. And so with this information, it's shared with the team. So once a week our team meets and we talk about the patients that came in the week before, and we plan their next review, and we also the nurse hands over the triage information for the patients that are coming in on that day. The other way we hand over our triage information, of course, is in our medical history in vitro, and we also use a shared care plan. So we write on the care plan the goals that the patient actually wants addressed in their appointment, and clinicians can access that. At this team meeting, we always ring through to our lovely MND regional advisors, and we share the information with them as well. So 90% of clinicians felt that they were better prepared after accessing the triage information, and 95% felt that the team was better prepared. 71% thinks that it helps prepare the patient and the family for their clinic visit. And some of the comments from the clinicians: if triage picks up no longer able to stand, physio-OT can plan and organise a hoist or a power wheelchair. Often the planting of a seed at the triage conversation is the beginning of education and acceptance. Issues from a patient carer perspective are vital to care. Clinician can get straight into it. 5 minutes? Thank you. Decreases information gathering and less repetition for the patient. That's really important because sometimes the patients might be in the clinic for 4 hours. So every time they meet with another clinician, if they need to tell their story again, it's very fatiguing. It allows me to discuss appropriate allied health or palliative care to help direct the conversations in difficult cases. And the gentleman that I called was a perfect example of that. We talked through palliative care. He declined it on the phone call, but once he met with his neurologist and unpacked that a little bit more, he agreed that it would be helpful. And so I asked the patients if they could brainstorm and give me some ideas, how we could do this better. And some of the comments were, I don't believe it needs changing at all. A mid-appointment call rather than a couple of weeks before they come in. Yes, no questions on triage email would assist with less writing as my typing diminishes, and it's helpful how it is. So in conclusion, survey results strongly support the triage process. It highlights a need to introduce patient education earlier and increase patient understanding why the nurse calls to get a bit more of their buy-in. 66%, I think that was quite low. So perhaps we have to focus each time the patient comes in, reminding them why we will be calling. And often they do say at the end of the consultation with the medical and nursing review, I'll wait till Mary-Ann calls and I'll talk about that. So there is buy-in with some, but that's an area that we can improve. So the take-home message, it enables patient autonomy, presenting the opportunity to discuss their disease progression in the comfort of their home. It helps identify priorities for review in their clinic visit. The triage conversation educates and prepares the patient for review. It prepares the team to meet the patient's needs on the day, and the patient sees the right clinicians, which is effective use of resources. Thank you.
So we've got time for one or two questions. Want to put your hand up if you have any? Oh, okay, thank you. Oh.
How long does the phone call take? Usually about half an hour, but it can be a little bit longer, it can be a little bit shorter, it depends. And I think the important thing is that's where the nurse is really building a very strong therapeutic relationship. You have time, you're not rushed in clinic. I think patients feel very comfortable having a chat to you, and we can really unpack and hear their story. And of course, as a nurse with your assessment, you have no visuals, so you're really asking a patient to identify, to paint a picture. So it depends on what the issues are. Yeah. Thanks. Oh, one more.
My voice is probably big enough.
You don't need a microphone, Jeff.
Do you include the carer in these calls at all?
That's a really good question. Often it's the carer who I'm talking to. Not always the patient can talk. Sometimes it'll be on loudspeaker, so I'll be talking with the carer and with the patient. And just recently I had a conversation with a lovely wife of a patient. This gentleman's only in his early 50s, and again it's his physical disability that's really impacting on him and the burden placed on his wife. He wasn't there at the time of the call, but we went through a lot of the usual conversations that I do have with the patient. She was able to answer every question, and I've got to know this couple. He's probably travelling quite quickly, only diagnosed March this year. He already has NIV and PEG, and he's at the stage where it's more difficult for him to turn in bed. He's just able to stand and get himself off the toilet. And in fact, he was coming in to see Sarah Solomon, and she'd already raised electric bed, and his wife was saying that when he's in bed, he starts on one side, he can roll over on his back, he doesn't have any orthopnea, but after a little while he's uncomfortable, he needs to wake her to roll to the other side. And, you know, as I said, you get to know these patients really well, chatting to them at home, and you get to know the carers, and I knew this would be a big step for him, but I thought if he was in an electrical bed, a hospital bed, he'd be able to raise the head of the bed, he'd be able to use the knee brake. That could change his position just a little bit. She was also saying it's really hard to get him up out of the bed. So it was very nice that I could raise this with his wife, not in front of him, just to see how she feels. Would this be a good conversation to have? And she said she thought it would be too much for him, but she'd really like me to let Sarah know, and Sarah can gauge on the day whether to go there with that conversation. And this would really help her. She was really saying, I'm getting really tired. So to answer your question, yes, we do support the carer in those conversations, and that's often the person who I'm talking to.
But how do you cross over with the MND Association, the advisors in this? Because it would seem that in our situation in South Australia, the deal of that conversation is with the advisor in the home visit.
No, well, I'm calling patients because they're coming into the clinic. They're going to come in for their appointment in 2 weeks' time. We have so many appointments available, booked for them with Allied Health. If that gentleman, the example I just gave, was coming in to see a speech therapist, a dietitian, the neurologist, and have a lung function, and I recognise it might be important for him to see his occupational therapist, I would book that appointment in, he'd see Sarah, and if it was appropriate, they'd talk about the bed. The week after, at our team meeting, we ring the regional advisors and we let them know, you know, Sarah's put in a request for an electric bed, this person's changing. The regional advisor will say, well, actually, I'm going out there, or I already went out there, I was going to identify the same thing. So we work with them in that way. At our weekly team meeting, we ring them and chat.
Thank you.
Yeah. Thank you.
And I guess what these conversations are showing is different states have different models and way that they work with associations as well as within the clinics themselves. So I think it's good to showcase a number of different models because, as we know, there are many different ways to provide services. So sharing of that within this venue can have others think about how can you make this happen in your community. And I know in New South Wales we have some very small clinics that have set up by listening to each other and how we can provide that with no funding, of course. So thank you. I'd like to introduce Christine Batten now. Christine has been a social worker in Tasmanian health organisation Palliative Care Service since 2004. Over that time, she has participated extensively in multidisciplinary teamwork supporting MND patients and their families and carers, both in community and in the palliative care unit. Welcome, Christine.
Hello, my first challenge will be using the technology actually. So, sorry, just click that one. Okay, so there are two of us. Christine's mentioned. I'll just say this on the slide. Only one of us speaking. My colleague Christine Edwards, palliative care medical specialist, helped with the preparation, and she's over here along with a small Tasmanian contingent. Okay, so I'll get started. First, I thought I'd give you the Tasmanian context. Basically, demographically, we're a very small population in the state, 546,000 in total. We have very low socioeconomics, a high incidence of chronic disease, and a high percentage of people aged over 65. At the last ABS census, it was 20.3% over 65. At another 8%, and that's all the people over 60, so around about 30%. And we have very little access to public transport outside of major population centres. The little photograph that I've put in is a good example of our topography, really. There's a lot of water around us as an island, and it's pretty hilly, and we're largely rural as well. Healthcare-wise, there's a very high demand for health services in Tasmania. There's a high demand for community support services as well. One thing that I guess has been alluded to in various ways today as well is there's an increasing administrative fragmentation of service provision. So sometimes communication and coordination across the broader system is difficult, and it's often indirect as well, which adds to things. In terms of MND, there is no specialist MND clinic or team in Tasmania. The area that I'll be speaking about today is purely the one in blue, southern Tasmania. I can't speak to what's happening in other areas of the state. Hobart is located just under the south label, and our population in southern Tasmania is roughly 240. Come closer? Okay, sorry. All right, so I won't labour this point. As we've all heard, best practice in MND care is holistic, multidisciplinary team approach from diagnosis for both the person with MND and their families. MND Australia has outlined 4 really good aspects for this: expert assessment of needs, capacity for rapid response, coordinated action and regular review being essential aspects. In terms of our experience, there is no definitive referral pathway following an MND diagnosis in southern Tasmania. Most of the diagnoses are through the Royal Hobart Hospital, neurology clinic, and some obviously from interstate. People's experience after diagnosis varies widely, and it depends on a variety of factors. Individual neurologists, where some neurologists will refer directly to MND Australia, some will refer to Palliative Care, some I'm not quite sure. Immediate needs, it also depends on immediate needs identified at the time of diagnosis, so whatever is uppermost may well be the thing that gets the most attention. And also, and primarily, the preferences of the person with MND and their family carers. For some people, as you probably clearly know anyway, a diagnosis such as this is shocking and overwhelming at the time often, and people are sometimes not ready to be referred to anything else in that moment. Our experience is that referral to MND Australia usually facilitates referral to other health professionals in the most timely manner. However, as it's been said already, sometimes that's declined, and what we also find is if it's not declined, often the referral will be deferred until the person and their families are ready. Best practice in MND care also includes early referral to palliative care, which is the service that Chris and I represent, and this is often scary and confronting and declined at the time. So in order to work from a multidisciplinary team perspective, this is how our team has developed. So in the absence of a specialist clinic or team in Southern Tas, we started with informal bi-monthly meetings, multidisciplinary team meetings in mid-2010. And what we wanted to do was improve and facilitate care in the most timely manner we could. So our MDT is comprised of Tasmanian Health Service professionals, so we're all from the Government Health Service, from a range of disciplines and teams within that broader service. All members have a special interest in MND and a commitment to offering the best care we can for people with MND and their families. And a particular note, people with MND and their families do not attend the meetings, so they are purely for health professionals. So there's some of the disciplines which do attend. There's a list there. Some of us attend regularly, others will attend as they have clients involved with something particular that they might want to report. People will change jobs, will change roles, so the faces of the clinicians who actually do attend can change. Some of us, as I said, have been there from the outset. Our MDT, as has been often mentioned today, has a person-centred care focus. Each person on our MDT list is reviewed at each meeting. We look at actions, identify issues and plan care with regard to the needs and preferences of each person with MND and their family. Again, reiterating what's been said over and over today, that what is primarily important is what the person with MND and their carers most need. Complications and progression are anticipated, discussed and planned for. Our MDT approach aims to increase our capacity for rapid response to changing situations and to minimise the likelihood of crises. Now, given the complexity of an illness such as MND, crises are likely to happen, and what we are doing, as I guess we all are, is really trying to reduce the likelihood of this. The incidence of MND in Tasmania, well, it's really difficult to know the incidence in Tasmania, as there is no MND clinic, there's no statewide register, and not all people diagnosed register with MND Australia. So as a result, what we're working with is the data from our multidisciplinary team in the south only. So we're a very, very small cohort in comparison with some of the numbers that people have spoken about today. Our team has worked with 70 people with MND, plus their family carers in the last 8 years. The average number of people on our list at each meeting has increased from 6 in 2010 to an average of 15 in 2018. We have some hypotheses around that. We have more neurologists now. It's gone from approximately 2 in 2010 to, I think it's 5 or 6 now in 2018. So earlier diagnosis, given that people are not having to wait for so long to see a neurologist, possibly also an overall increase in incidence, but as I say, we don't know. We're not able to get those kind of numbers at this stage as to what is happening. How people generally access us. The first health professional from our multidisciplinary team who has contact with a person explains the role of the meeting and will ask permission to discuss their situation with the team. So our aim really is to introduce the whole team concept as early as we can, bearing in mind that we are not actually a designated team. We are formally informal, I guess, or informally formal, whatever you'd say. There is no single point of contact for us. Okay, so I just wanted very quickly to talk about a client who we worked with recently. Her symptoms came on in October and she actually died in late June of this year. I've had her family's permission to speak about her. I've de-identified her by name, and this is not a photograph of her family, but it could well be, right? So when we first met Jade, she had received a definitive diagnosis. So from the onset of symptoms in October, definitive diagnosis didn't occur until May. Throughout that period, she was being treated for what they thought might have been multiple sclerosis, and not until May were they able to definitively say that it was MND. So we met Jade immediately after her diagnosis. We had an urgent referral to the specialist palliative care team from her neurologist. When we met her, as you can see, it's a really busy slide. And when you think about the compression of things that happen over a 6-week period, it is a really busy business anyway. So on the left-hand side, we're dealing with the physical manifestations of her illness. On the right-hand side, some of the practical issues that were also really important at the time, getting her legal affairs in order. Jade had been a stay-at-home parent. Her children were 11, 13 and 15 still at home, and a pregnant 21-year-old who had moved out of home. So finances were an issue. Her husband was the primary breadwinner, had to stop working. Then we're rolling into dealing with Centrelink. We're also needing to get equipment. She lived in a rural area, so transport to and from anywhere became difficult. She needed to access superannuation in order to be able to purchase equipment and actually modify things and obtain a vehicle that she could get around in. Support for her carer was a primary issue as well. Her husband was caring for their 3 younger children and her full-time. Maintaining the care and routines of the children was a primary concern, and as I've said, access to services. Now, Jade's primary concerns were her children, as you can read up there, husband, also dealing with extended family needs in terms of their response to her illness and what the things that they wanted to do with her or to suggest to her, pressures and expectations from her social network, people wanting to have contact, people wanting to come and see her, people wanting to do things with her children, a whole lot of good and difficult things all at once. The speed of her disease progression was frightening, really, and one of her greatest challenges was also managing her grief in terms of being able to be present with her children and her husband and her family without showing active distress all the time. She just wanted to be able to be with them solidly. Okay, so the services that were involved from a multidisciplinary team perspective over the 6-week period that we had contact with Jade were all those ones on the left, including the end-of-life support service nurse right at the end. Now, one of the things that I'd like to point out is that on the right-hand side we have Jade's highest priorities, which were private time with her family, time with her extended family, and things like being able to attend her children's important school and extracurricular events. So the things that were needed, the services that were needed, the health professionals who came in were all really helpful, but you're also dealing with the tension between all of that and Jade's needs for time to be with the people who were really important to her. So one of the advantages of experienced clinicians, I'll just get through this as quickly as I can, is we were able to review Jade and her husband's needs at each contact because the clinicians involved were able to identify and anticipate changes beyond our own discipline as well. If you have a familiarity, then you can identify other things. Capacity to communicate quickly to other services, patient and family feedback. We were able to look at collaborative problem solving as issues were identified. We made joint visits wherever possible to reduce intrusion, and we were all aware of what was happening and prepared for rapid response. Finally, I'd like to say the benefits for MDT members. MND does arouse strong emotional and ethical challenges for everyone involved, and a significant strength of the MDT for us is its ability to support the various team members in their work with what is often very challenging and complex situations. And that's it really. And the other benefit is that our members are also a resource for colleagues within their own teams. Where to from here? That's the sunrise. We would really like, again, as someone said, to be done out of a job in terms of this work. Yeah, okay, thank you.
I'll leave that there for a moment. It's a nice photo. Thank you, Christine. Our final speaker for this session is Samantha Mitchell. Samantha completed a Bachelor of Health Science in Speech Pathology at Charles Sturt University in Albury in 2008. She's worked in the Goulburn Valley Health since 2009 across a variety of settings. She commenced work in Community Rehab Centre in 2014 and worked with multiple MND clients during that time. Samantha has a particular interest in dysphagia management and neurological conditions. Welcome, Samantha.
Thank you very much. As was already stated, my name's Samantha Mitchell. I work as a speech pathologist at Goulburn Health in Victoria, and today I will be presenting on MND care, a regional approach. During today's presentation, I will provide an overview of how our service runs, discuss the team's model of care, and outline team initiatives that have been introduced recently when involved in the care of clients with MND. So a little bit about us. The Community Rehab Centre, or CRC, is an outpatient rehab facility and is located in the heart of Victoria in Shepparton. We are an interdisciplinary team comprised of a multitude of clinicians, in particular physio, OT, diet, speech and social work, and the other disciplines listed. We have an overall EFT of about 11 across all disciplines, with most clinicians working in a part-time capacity within the program. The majority of our clients are seen in clinic for a single discipline appointment. However, joint and back-to-back appointments are also offered, and the team runs a multitude of groups and several specialty clinics. One thing we do want to highlight is that MND care is only a small portion of the work that the team does. We provide a unique service to our region when working with clients living with MND, being able to follow clients throughout their journey. Consultations occur in clinic, at home as disease progression occurs and clinic appointments are no longer able to be attended, and in residential care facilities as required. This ongoing care and client follow-through cannot occur in all teams, and we realise this is very unique to us, and the issues relating to this are largely impacted by funding restrictions. This approach is quite beneficial to our clients and their caregivers. It reduces the number of changeovers between clinicians and teams throughout their journey, in particular at end of life or if they do need to enter a residential care facility. Disease progression can be more closely monitored by clinicians rather than handing over to another team and starting afresh, leading to clinicians being able to anticipate and meet needs more quickly. CRC provides a service to a large region encompassing 4 or 5 local government areas in Victoria, being Greater Shepparton, Moira, Strathbogie and Campaspe Shires, in addition to the lower Riverina of New South Wales as required, and the team may also look at taking referrals from the Mitchell Shire on an individual client basis, depending on where the client's GP and support networks are located and the normal travel direction for clients in accessing services, either towards the Goulburn Valley region or towards Melbourne. Over the last 10 years, the CRC team has been involved in the care of 20 clients living with MND, with the number of referrals received per year increasing in the last 3 years. This has resulted in the team being actively involved with between 3 to 5 clients living with MND at any given time. For a small service that covers quite a large area, this can be quite challenging for a number of different reasons, particularly travel time to see clients, or when multiple clients living with MND are going through periods of disease progression at the same time, which can result in several home visits being required in quite a close time frame. For clients living with MND who are able to attend our clinic appointments, travel is always involved. However, this can become problematic as mobility and transfers become more difficult and time-consuming, potentially leading to a decrease in them accessing much-needed allied health supports. Home visits are offered to assist in alleviating these issues. Due to the large regional area the CRC team covers, this can involve travelling over 1.5 hours or up to 100 kilometres each way to see some clients living with MND, depending on where they are located. As you can imagine, this can result in an interrupted daily schedule for clinicians at times, particularly if urgent or emergency appointments are required, but the benefits for clients living with MND and their carers are significant and far outweigh these inconveniences for us. Living in a regional area has many benefits. However, there are also barriers for clients with progressive neuroconditions, including MND, when accessing services and in regards to care provision. Clients may have difficulties accessing services, are restricted in how, when, and who will provide these services, and there may be limitations in the availability of public transport or wheelchair accessible taxis. Working across the various local government areas, the differences in service provision are often highlighted by team members, particularly whether or not there is a case manager involved to assist the client and the family to navigate and coordinate these services, and the differences with palliative care service provision. Clinicians are regularly involved in educating services and care providers about what MND is and advocating for increases in care provision and changes as required to assist with service provision and symptom management. So onto our model of care. The CRC team takes a neuropalliative rehab approach with all clients living with MND and other progressive neuroconditions, aiming to maintain independence and overall function for as long as possible while planning for deterioration and anticipating future needs. Our model of care involves conducting an initial team meet and greet with family. The client and care providers are also invited at times to determine current deficits and needs. From here, a care plan is developed, which may involve further discipline-specific assessments, arranging equipment trials and delivery, funding applications, and referrals to relevant service providers. Areas that the team has particular clinical expertise in includes advanced neurology skills, PEG education and management, and the assessment and management of complex equipment needs. We aim to provide joint clinician appointments as able. Previously, appointments would largely be single discipline, resulting in back-to-back clinic appointments with different clinicians, or multiple appointments per week or fortnight as required. Further information about joint appointments will be discussed shortly. The CRC team also offers bereavement support for families, caregivers, service providers, and care facility staff members. This is not limited to a particular number of sessions nor duration following death, but is available for as long as the individual requires. Caring for clients living with MND can be quite intensive for all involved, not just the family. It is important that everyone involved in the care process has the opportunity to grieve and debrief, either as a team or on an individual needs basis. As we all know, self-care is very important. Our team regularly meets to debrief and discuss complex clients, particularly after they pass away, to allow closure and for clinicians to move forward and think about what they could change for the next client we are involved with who has MND. Clients living with MND can be potentially involved with between 15 to 20 services at any given time, which can result in significant burden and time constraints for clients and caregivers, with multiple phone calls, visitors, appointments, and services visiting their home per day and week. By having a case manager on board, this can assist in reducing the number of contacts for the client and family and somewhat streamline the process. There are multiple benefits of joint appointments for clients living with MND, caregivers and staff, including coordinated care between team members and various services, education to clients, family and care providers, equipment setup, particularly in regards to wheelchairs, hoists and eye gaze devices for communication and environmental controls, problem solving any issues for the client, family and care providers, a reduction in the number of appointments per week, and peer learning. A change in team practices has resulted in the scheduling of more joint appointments where able to minimise the time burden on the client living with MND and their family or caregivers. The majority of single discipline appointments that now occur for our team are for equipment setup or in response to a deterioration in a client's condition that requires immediate attention. Another advantage of joint appointments that has been highlighted in particular is peer learning. Working in a regional healthcare setting, the care of clients living with MND and other progressive neuroconditions often falls upon more senior, experienced clinicians. This can lead to staff burnout, as well as a loss of skills and knowledge base should these clinicians leave the CRCD department or the health service overall. This model allows for staff upskilling to occur for both junior staff and staff from other disciplines who have limited experience in MND care, who may be the only clinician for their discipline within our team. Each client living with MND presents unique learning experiences and challenges for the CRC team. Recent team initiatives that have been introduced to improve our model of care and service provision. These include bi-monthly team meetings that occur with our MND Vic advisor for the team to discuss the clients living with MND we're currently involved with, provide an update and discuss any issues, advise of any upcoming appointments or services that are coming into play, and flagging any clients in the area with a recent MND diagnosis who may be referred to our service. We also have improved links with Calvary Health Care Bethlehem, with many clinicians recently attending professional development days at the facility, and this has resulted in the opportunity for us to meet a number of different staff and awareness of and use of the advisory service, improve shared care of clients accessing Calvary Bethlehem for specialty appointments with local follow-up and ongoing care by the CRC team following these appointments. We conduct regular meetings with clients, family and relevant service care providers, allowing for discussions about the current needs of the client, arranging referrals and increased services as required, and following up equipment trials and clinician reviews. And we've also developed a MND checklist form, which our team uses during family meetings, assessment and review appointments. It prompts clinicians to look beyond single discipline issues by asking more holistic questions that may arise from a symptom and care perspective for the client living with MND, and arrange referrals and follow-up as required. Early anecdotal evaluation of these initiatives indicates an improvement in care coordination of services, greater anticipation of and planning for clients' future needs, and clinicians addressing clients living with MND more holistically, not just on issues relating to their discipline. So, moving forward, with any changes to service provision, there needs to be ongoing evaluations to ensure growth and improvements occur. Future evaluations and changes we plan to consider include a formal audit into the impact of joint appointments, comparing the number of clinician interactions and the number of appointments that we provide, seeking client, family and care provider feedback in regards to our model of care and what changes could be improved to our service, a staff survey in regards to knowledge base and how peer learning is working, and also the increased use of telehealth, with looking at introducing this to more routine review appointments for checking in, but also potentially being involved with clinic appointments that the clients have with Calvary Health Care. One last thing is that the NDIS doesn't roll out in our area until January next year. So early discussions from a GV health perspective is that we're a bit up in the air, which is unfortunate as the health facility doesn't have a standpoint and we're only a couple of months out. And we're hoping that this doesn't impact on how we work as a team when managing clients with a progressive neurocondition, including MND, because I've already highlighted the benefits of joint appointments and how clinicians can work together to get the best for our clients, not just now, but planning for the future. And just in summary, I suppose we just want to highlight how quality service provision can occur in a regional setting and the ability to follow clients through their MND journey from diagnosis to wherever their life may end, be it at home or in a care facility, the benefits of joint appointments, and also how peer learning opportunities can be set up and created in all services. Thank you very much.
Okay, thank you, Samantha, for that talk. I was wanting to ask about the NDIS and what impact it has, because I know that in New South Wales we've seen a lot of impact, and you know, it's great to see all these creative models, and then how do we do that in the new world with the NDIS is a real challenge. So thank you, and thank you to everyone who presented this session. I think it's given us a good view from care through to, you know, models of how we can actually approach this care as we go along, and how we can talk to our people with MND and their carers. So thank you very much to everyone. So this is now lunchtime, which I know we've all been looking forward to. There's probably some yummy food out there. Just remind you that there are posters and trade displays out there and other resources to have a look at over the lunch break. We'll be back in the room and ready to start at 1:30, so if I can ask you to move into the room once the bell starts ringing. And could people for the next session please meet with Carol Burks at 1:20 at the front of the room. Okay, enjoy your lunch.